Very good. So I wanted to say it's a pleasure to see you all and to meet. And I like to hear the voice of the patient. I have a lot of scientific enthusiasm. We are at a very special stage to have something to offer for brain tumors, which we need joint efforts to make it happen, and the patients should benefit. I trained as a pediatric oncologist and have great interest in innovative treatment. I can't hide my Swiss accent, where I studied, and I trained afterwards in Canada, the fellowship in pediatrics, Toronto Hospital for Sick Children. And my interests for over 20 years are brain tumors. We worked on angiogenesis, Judah Folkman, which did not turn out, unfortunately, to be the big success. And I learned about these viruses 25 years ago. I will not go in much details. What I would like to do today is to present you one patient and to hear afterwards the patient's perspective. That's a meeting with patients. And I would like to ask you, for me, it is helpful to talk to patients, to hear and to learn more. And on the other hand, to also explain you how difficult it is, really difficult, to start such a project. But I don't see the difficulties. I see the outstanding opportunity that we have something new in the field, which is literally life-saving. And there is no excuse that anybody could run away. I'm talking to myself not to make it happen. It is very difficult, but I will talk about my difficulties later. I want to talk about the cancer. So I have a presentation ready here, which I gave, Sorry. Here it is, which I gave earlier this year, a month ago, in Germany. And I have the honor to work with Dr. Shahinbash and Dr. Schmitz in Düsseldorf, two outstanding, an oncologist and a neurosurgeon. And you will see how critical it is. And the topic of the lecture is intratumoral specific immunotherapy. Here you see our German. It's the first experience and results. And I want to share that with you. Oh, here it's translated to English. I believe it's a historical breakthrough, which has many innovations, need a lot of time, a lot of study. And even if it's proven, I think it's proven black and white what I'm going to say you. What I'm going to show you, I think it's not black and white, it's white on black. That's the MRI shows it, and other colors. It's totally proven that it works in one case here, one case there. So we have good preliminary results, and it's good enough for me to focus on this research to make it happen, and good enough to tell the patients, we should talk at the end which one qualified, to tell them, I hope, I can't say, I think, I cannot say I'm sure, but I hope we have something to offer. If we don't try, we have for sure nothing to offer. So we are a company based in Israel called Beni Gesundheit Institute. It's actually virotherapy for innovative, a charity company for innovative treatment. And Beni Gesundheit Institute, because it's my name, and Gesundheit was taken. I will say a few words on the successful treatment of relapsed anaplastic astrocytoma called AA. GBM, glioblastoma multiforme, and other brain tumors. We have oligodendral and many other types of tumor, the pilocytic astrocytoma and mixed forms. And what I want to show, is there something new to offer where others stop? If it is localized breast cancer, I don't feel anything. I don't feel I should do anything to help with a new idea, because localized breast cancer is in most cases treatable. However, when it comes to brain tumors, and for sure relapsed cases, the chances are very little, if not to see it very clearly, they are doomed. GBM is by definition not curable. With all efforts, and you will see miracles, these are words which are not supported by epidemiological studies. Everybody knows that, but that's the doctor's talk. So the survival curves, I will show it in a moment, are poor. The intratumoral injection of oncolytic virotherapy, and I will use later on the Inrra-ommaya, injection, which is a ommaya, I will explain in a moment, is a port which goes directly to the place, to the brain tumor, or to the CSF, to the cerebral spinal fluid, is a total innovation, and it's new on the field. I work very intense with Dr. Jajadeepa, a brilliant radiologist in Bangalore. We have weekly several sessions on all patients, and that's the basis to understand the patient. I pay a lot of attention for that to make sure we understand, and she uses new technologies, which I think your radiologist not only doesn't know what she shows, they even don't have the equipment or think they don't need the equipment. And I will show you in a moment why it is critically important to know what we are dealing with. Know your enemy and know him very well and try to know him better in order to do the best. I will present the case story, the case presentation, and the future considerations the way I see it. I will give it to you in a few words. The focus will be to show the radiology, because I think even you are not a professional radiologist, that's what the follow-up tells us. We have no other tools. So a brain tumor here for anaplastic astrocytoma, once it appears in one place, for sure for GBM, and other tumors as well, they have from beginning spread to the entire brain. Very often, if one lesion is operated on and the surgeon proudly says, we took everything out with clear margins, he knows, and the pathologist knows, and everybody knows the clear margins are not clean, because even if it was just here, the tumor had from day one a spread of a few cells to another lesion. And in very early years, they did very generous resection, and it was not successful either. So we cannot cure by surgery nor radiation, and chemotherapy is unfortunately not very successful in brain tumors. There is a blood-brain barrier, BBB, which makes it difficult to get there. And here we have the overall survival for anaplastic astrocytoma, the so-called Kaplan-Meier, which is poor. And there is a lot of publications. What is done classically, for instance, for GBM is surgery, radiation, and if MGMT positive, Thimadol, and very often they give it anyway because nothing else to offer. So why not to give it? We have nothing else to do. And other chemotherapy, which unfortunately proved not to be successful. How does a virus work? The virus is a little particle which goes to the cell, passes the membrane, and multiplies and attacks the cell. The oncolytic viruses are species specific. A chicken is affected because there are very interesting special tropisms at the surface of the cell. The human cell will not allow the virus to enter the cell. Basically, nothing happens. Might be a little flu-like symptoms, a cough, a low fever, low temperature, or joint pain, common flu. And it goes away in 2 or 3 days. That happens to the cell if they're not really attacked. They remain undamaged. However, the tumor cells has a weakness, as the chicken cell has. And if the tumor cells, if there is an invasion of the oncolytic virus, which the tumor cells is not a stable cell, fastly growing, replicating, if they enter, and they do so, they replicate within the cells from 1 to 2, from 2 to 4, and they destroy the stability of the tumor cells. That is one effect. By virus replication, the stability of the architecture of the tumor cells is destroyed, gone, bingo. We have, instead of one virus, we have hundreds. And they enter exactly the adjacent cells. They will not do anything to the healthy brain tumor, to the healthy brain cells, because they can't enter. They behave like that. But they do destroy, and more viruses are secreted, and they induce a local inflammation. You will see that radiologically. So that is an outstanding targeted mechanism which needs to be used at full power. This destruction. We have OVs, they do not attack the healthy cells. It's very targeted. A patient who had surgeries, who had radiation, and everything is sore and operated and scars, we can still offer something, one arrow exactly to the cell, to the tumor cells. And that is a major advantage. They can be injected intratumorally, like breast cancer and other types of cancer. And they have the double effect, as I showed here and here. And let me tell you the story. It was in the 60s that a patient with metastatic gastric cancer was diagnosed in Newcastle with an end-stage cancer. And the doctor told him, unfortunately, nothing to offer you. We don't know how to treat metastatic gastric cancer. They didn't know these days, and today it's not really treatable either. The patient should go home, write the last will, and say goodbye to all his family and friends. That's what he did. Unfortunately, he was a chicken farmer. All his chicken died. That's what he liked to do. All the chicken died, and he had hundreds of chicken. And once they died, he had to evacuate them. And he worked for several days. Poor guy and the chicken farmer. And here the story, it's a very, very educational story. We can learn a lot. He evacuated all the dead chicken and was exposed to that. To make a long story short, 3 years later, he sees his doctor on the street. And with a lot of patient's discretion, the doctor asked him, "Excuse me, sir, do you have any twin brother who must have died 3 years ago?" So the patient says, "Oh, don't you remember me? I'm your patient. I have no siblings. And you know what happened? All the chicken died." The doctor was asking about the tumor, and the patient was talking about the chicken. It was a really good dialogue. Everybody spoke, and nobody listened to the other. And the doctor wanted to know what he did. He couldn't believe he's still around and he is healthy. He checked all the documents and found out it is a metastatic gastric cancer, and he couldn't understand why he is still around. It bothered his mind, and all of a sudden he had a brilliant idea. He listened to the patient. That is the brilliant idea. And the patient told him, "All my chicken died." So the death of the chicken, if you could please mute you, the death of all the chicken was actually the beginning of his cure, because he was exposed to the chicken virus, which killed all the chicken, but he survived. And the doctor wrote a little medical letter in the mid-60s, "Do chicken virus kill tumors?" And that was the beginning of the field. It was actually known before. These are the mechanisms which I will not present you today with all the fascinating immune mechanism. It's a local destruction, the direct oncolytic effect, and the very intense immune activation locally. The more tumor cells, the stronger. So we have actually a built-in factory in the patient's brain, which will tell us what the best dosage is. We give very little. If they stick and attack one tumor cells, they replicate and will give the paste for the right tumor amount we need, virus load to treat. And that is the story, which is fascinating story in medical history, but that's not the purpose. We know it from the late 19th century. And today there are some viruses, the TVEC, which are approved for melanoma. I got involved in the field over 5 years ago when I had the privilege to publish for Frontiers as a guest editor, a volume on oncolytic viruses and genetic engineering, a group of 17 researchers. And today it's over 100,000 views. It's really a fascinating field for many, many tumor types. I published 4 cases in 2020, which I reviewed with a long-term survival of glioblastoma, not yet Inrra-ommaya, but it was given intravenously or intraarterially. So it works. And in basic research, it works. And here we have the patient, which I would like to present you today. a lady born in 84. At the age of 22, she was diagnosed. She had seizures, and anaplastic astrocytoma was found in the pathology after the surgery. And with various treatments in between 2006 to 22, we talk about a period of 16 years. There were a relapse. Timodal was given. I don't understand why, because it's known that many doctors give it. I don't understand why. That's not what the literature supports. She got radiation and Timodal and relapsed in 22 after a history of 16 years. Seizures and a radiological multifocal relapse. The condition is end stage because you cannot operate again. You will see what the size of the disease was, a multifocal relapse. She got everything possible, radiation and treatments, and she had an MRI, which I will show you, just pre-treatment. And now I invite you a little bit to the radiology ward, but let's first summarize the clinical complaints. Hemiparesis of the right leg and arm got worse and worse. Seizures got worse. Weakness to raise the arm, worse. Fine motor skills, worse. The vision and the mood, of course, got all worse. And here we had a one-time injection of a very small amount of these viruses. They don't have to pass the blood-brain barrier. They were injected, and there were 1, 2, 3 following imaging studies with PET-FET, a very sophisticated imaging. You will see in a moment that MRI is by far not enough. And the clinical course changed. We will hear it afterwards from the mouth of the patient and her husband. And all these parameters got better after several months. And I want to show you now how that works. That is Mr. Ommaya, who invented this Ommaya port or Inrra-ommaya implant, which goes here under the skin, and it can be implanted here or here, wherever we wish it, or wherever the neurosurgeon is told to implant it. It's a little plastic tube tap, and it gets very close to the tumor in the fluid of the brain, the CSF, cerebrospinal fluid, or even into the tumor. We need to get very close because the concept is where there is a fire, we bring the water. We don't need to put the whole neighborhood underwater. It's enough to bring the water just to the fire. And we have to be targeted. No blood-brain barrier on the way blocks us off. And that's the way it looks like in our patient. It looks good while the surgery. The patient is asleep, and that is the size that needs to be open. At this size, this plastic is implanted, and the needle goes directly to the focus of the tumor. It's a highly targeted, mechanically speaking, a highly targeted treatment. Biologically, very targeted, because the oncolytic virus attack only the tumor cells. They do not attack the normal cells. However, if they're around with the Ommaya and the tumor is here or here or here, the circulation in the brain brings the viruses to every single individual tumor cells. It's not surgery that I have to run with a knife after every cell. We can't do that. It's not chemo, which affects the normal tissue and the patient's normal well-being, and also a little bit, sometimes not, the tumor cells. It's highly targeted. So this needle, which looks of course wild to people who are not familiar to see that, is after such a surgery in the past is nothing. Relatively nothing. The quality of life is after the surgery, a day, 2, whatever is needed in the hospital, and it's a minor procedure. And that is Dr. Jajadipa, who helped me to review all the data. And it's like in the Indian parable of the blind man and the elephant. We need to look at it from different places in order to understand. That is new. To use oncolytic virus Ommaya via Ommaya, I don't think anybody else does it. And to look at the dynamic of the response is new. Nobody knows enough about it. And the different technology, it's really a new field, which has a lot of fascinating new insights. And what I'm going to show you now is one of the best pictures. We have several patients who had this response, but I don't know if you watch the Mondial for the soccer, but you will not see such a patient like here. And you will all say together, unmute your microphones. What I will show you now is more than messy. The success, what you will see here, is just unbelievable. You see here the MRI from April. There is one lesion, it's cut like that, coronal, and on different cuts, closer, more anterior and posterior, it is full. One lesion here and one lesion here and another lesion there. And actually here you see several lesions here, 1, 2, 3, 4. It is a metastatic condition. No surgeon would touch her, should touch her. And here, one single ommaya injection, and look at that. That is the big wow. It's gone. 3 months afterwards, oh, you can just see something, because here, nobody would recognize that's a tumor. But since we know this area was affected, oh, it's not symmetric, but nobody would make a tumor out of it. Wouldn't you know from the past that here was the biggest part of the tumor? And that is the ommaya which came in here. You see here the empty tumor bed, and the ommaya gets right away there. And here it's clean, and here it's clean. So at that point in time, I could say it's no evidence of disease radiologically. That makes me very happy, and the patient even more so. But we have to be critical. That's the MRI. The MRI shows the anatomy. And there are other techniques like the PET, which shows the metabolism, the functional metabolitic activity. I show the same here from the T1 MRI, and you see how amazingly it's enlarged, it's gone. Wow. And we could sign off here. Would we do only an MRI? No evidence of disease. It's not true. I say that with a lot of self-criticism. We need to search better and to find the best technology for the patients to make sure is still any cell around, any focus. And we did here the MRI, and we did the PET. The PET was done only later because the patient came to us. Nobody does a PET. We insist to do a PET. And here we have the MRI and another MRI. And we have here the PET. And the PET shows blue is normal activity. It's called the cold spots. They are not suspicious. However, so you see this lesion is gone and doesn't show off here. These lesions are gone. Might be something is left here. It's asymmetrical and nothing is seen here. But watch here. There is an empty hole and there is an empty hole. No, the radiologist will tell you no evidence of disease. So we could say proudly no evidence of disease, but I'm not interested to be proud on the results. I want to be right. We do the MRI and we see in the MRI there is disease. There is activity. How can that be that we see activity here and we don't see it there? Who is lying? Nobody is lying. We need to better understand. The viruses, remember, kill the tumor. The tumor is gone. But the virus causes an immune reaction. The immune reaction is seen. So we witness here the effect of immunotherapy. You can say here, that's the cancer here, and that's the immuno, and that's the therapy. Now look at the next picture. This immune reaction after another 3 months, 2 months is gone. There is an empty hole, because the tumor it's a punched out lesion. So we can be very proud and say, oh, we passed the first line. We thought it is no evidence of disease, but it actually is. In the PET, it is. No. And now it's clean. And I will show you a more sophisticated technology where we see here still some little minor evidence of disease. And that's what I'm going to show you here. Here you see, she has to be, hold on, admitted. So here you see a very minor, here you see the comparison in the PET, which we measured very carefully, very carefully with all the best technologies. And we see that even here, the study is not totally symmetric, because here we see nothing and there is a little dark cloud. We see still something. So we are very critical with our results. Might be something is hiding there. We need more treatment of the so-called minimal residual disease. We try to see what people don't see. And I'm telling you, if we brought a tumor from this size to shrink very little, and it's beyond resolution, we say no, move on and try to find what people don't see. And we insist on the best radiology. There is not one radiology which we could be done, which we don't want to be done if it helps us. And the doctors don't understand it, not covered by the insurance. We leave that for the discussion later. I take you now, after all the fascinating measurements here, which are academically highly great interest. Now remember what I showed you before. We called it for the second time, no evidence of disease. It's not true. Why? Because we use a special technology called the three-dimensional volume-rendered MIP inverse reaction, and we call that the soft angio preset and the soft tissue. And you see here, that is the three-dimensional technology. The radiologist knows to turn it around like an apple in your hands, from all sides, all left, right, anterior, posterior, superior, inferior. There is a minor residual disease, which we don't see in the PET. What we see here in the PET is for a long time invisible for the MRI. Don't believe the radiologist, there is no evidence of disease. These diseases will relapse in 5 years, in a year, in 5 months. We need to have the best microscope technology to make sure nothing is there, and still to be concerned to treat further. If somebody has a sinusitis and has a fever and headache, if he takes 5 days antibiotics, normally the fever is gone and the headache is over. But if you stop the antibiotics, you will have recurrent sinusitis. The same is true for a brain tumor. So if it's gone and we don't see it, we have only one conclusion that we can say: we don't see it. We have no conclusion to say with a certainty it's gone. So we have to be very careful and suspicious. For brain tumors, we are not waiting. We are not waiting till there is a relapse. We better treat more. You see here in the PET 3D virtual volume rendered soft tissue fluid preset, you see a tumor here, which is like a punched out lesion, not that intense. And look here, a tiny little lesion, not visible in the MRI. Something is still there. Don't underestimate the enemy, certainly not the GBM. And look here, another technology, which I will make bigger, and that's a star presentation. That is a tumor enlarged here. Here we see where the X is, that is the tumor. The cancer tissue is getting smaller, is fading off, is disappearing. Still present, the size is much smaller, and the intensity measured by the other technologies is going down most significantly. That much going down that it's actually invisible on the MRI and on the PET, but it is still there. Watch carefully. And the red halo is the immune reaction, because the viruses, they cause an attack of the immune system. If I have a foreign body in my finger, it hurts, it gets infected, it gets red and warm and tender. Classical signs of infection. The same happens in the brain. And you see here that the immune response, which is very strong here, is present here with this red shadow, is stronger here, and is here also present. That's the immune response. The immunology of the patient is our best friend. Don't kill your friends with chemo. It doesn't work in brain tumors. Nobody should tell me it works. The publications say the opposite. Why do they give it? Because the doctors have no more creative ideas. They have to do something. Oh, it doesn't work. Don't confuse them. They give chemo. Yeah, we never know. No, we know for sure it kills the immune system. It actually invites the relapse because the immune system is wiped out. What we do here is exactly the opposite. Activate the immune system, direct killing. Remember my slide at the beginning? By direct killing, kill the tumor by the virus as close as they can get, and they will cause, with the biology of the brain tumor, they will bring fragments of these dead cells which go to the system, and they will be recognized by the immune system, and the immune system knows exactly where to attack. They attack exactly here. So that is the cancer in this color and white on red, immunotherapy. And that is the fascinating mechanism of Inrra-ommaya, oncolytic virotherapy. That is the life-saving hope, which I would like to offer to you and every patient on this planet. So we summarize here that it is almost complete remission. I could say it is complete remission because in the MRI, you don't see it. I could say it is complete remission also according to the MRI, to the PET, because on the PET, this fire, the red fire is gone. But I will still say it's almost complete as long as I see something and I make all efforts possible to see something. It's almost gone, but the patient is much better. The quality of life, yes, it's not fun to have a foreign body under the skin, and certainly not in the brain. And we will hear afterwards, it is a very, very, very targeted treatment. All other therapeutic options are a long time ago gone, explored, exploit to the end. No chance that any surgeon should be stupid to open the brain again and take out the 6 different lesions, knowing that they will relapse. One shouldn't do that. It's highly unethical to do that. Palliation would be the alternative. I call it is a dose-adjusted treatment. We give a very tiny amount, super low. Why? Because if it's too strong, we'll have an overly strong immune reaction, which might be dangerous. We learned the best adjustment. This dose adjustment for the patient is dose adjusted by the patient. There is nothing more elegant than like a patient with diabetes, with insulin-dependent diabetes. He needs a pump. You measure the glucose level and automatically, or by a syringe, you measure all the time the glucose level and inject insulin accordingly. You don't need to do that. The body is doing that. The more tumor cells, the more virus attack, the more viruses are produced, the better is the immune response. Be very careful. Start with a very slow amount. We don't know how to quantify that. We have a lot of research ideas how to adjust that, but that is future music. It is cancer immunotherapy, slowly but surely. So I do that with the group. I will not undress, don't be nervous. With this enthusiasm, it is a total breakthrough, which I can do in Germany, because we have collaborators and the regulation is allowing to do that based on the Nuremberg doctor trials. I can do it in Germany, coming from Israel, and both parents are survivor of the Holocaust. It's a very special privilege to work and in a place where people were killed to save patients. It's an unbelievable privilege. We have very small amounts of case studies. We are not allowed to do formal studies. And we have the so-called p-value, which I define in my own way, not this purely statistical p-value, but we have a new philosophy to treat patients. And we have plans, and we need production of these viruses with protocol and permits, and a place to teach in physicians and patients in pediatrics and publication and payment and personal treatment and palliatives instead of palliative prevention. And we need partners and practical progress. And I ask you please to help. I hope that was a good explanation for my p-values, which I showed you here. And we attack different cancer types, with each of them has its own nature and its own features. We can inject much better in the breast than in the brain. and we can inject in the breast of the lady, in the axilla, and attack many, many other lesions, because there is an immune effect on distant lesions, which we are capable, not we, the virus is capable to attack in the so-called abscopal effect. It seems to be very close from the bench to the bedside, from the bench to the mensch, but there is actually a deep gap. Regulation, financial issues, we need great support. I'm supported by good people who help me, and it's not an easy one. We have the results. We are not an insurance company and cannot tell you what the statistics are. We have small groups, and I put all my energy to help each patient in the best way. And each patient is a world in itself, but there is a way to cross this gap. And we need help from everybody. The strongest people probably to help are the patients who survived and are doing well. And we will hear that in a moment. I want to thank a wonderful team of collaborators. And it's like in the circus, you need to know your skills very well, otherwise it can be very dangerous. And the most important part between the team is that we have to give a very, very good collaboration and a hand to each other to work in the full understanding who does what and what can we expect. So I'm pleased to ask now the patient to tell his perspective. As I told you, for me, it's a personal privilege that based on the Nuremberg doctor trials, we can do something good to the world. Where people killed and murdered, we should do the best. I want to thank you for your attention and ask Hannah and Pete to talk to us.
Well, first off, thank you, Dr. Beni. I know Hannah she is listening in, but she's not going to speak. She says she'll speak if I miss anything, but Hannah's been hit pretty hard by COVID. I had it, I probably gave it to her, and she's doing much better. But I mean, she's doing much better since COVID, but if I was going to tell you where she was a few months ago compared to where she is, it's almost unrecognizable. There was no question that what was happening was happening fast, and it was massively affecting her life. In fact, we were both preparing for the worst. You know, we literally, that's where we were with things. And to see the turnaround since Hannah's been under the care of Dr. Beni and Dr. Shamibas and Dr. Andreas, and also Dr. Ziggy here in the UK, it is, and I obviously I can use this word, you know, because I'm not a doctor, but I would say it is a miracle what has happened and the turnaround. And I'm very, very, very grateful because Hannah has a life. Obviously, we were actually going back to Munich this week actually, but because we've had COVID, to have another scan, and we would love to have presented that scan to everybody here. That was the plan, but we're going to have to wait until the new year. I cannot speak highly enough of the work that everybody does, how much care has been given to Hannah in having the Ommaya. She's now had the Ommaya taken out. She's had 2 doses of the virus, the 2 different viruses, and the last one was in, I think it was in October, if I remember correctly. But if anyone has any questions, beautiful, feel free to ask any questions that you might have.
I just wanted to thank you both. Beni, I think your understanding was great, and the pitch was absolutely perfect for this audience who've done the research. They've looked, you know, at innovative and adaptive treatments. I've got quite a lot I want to say, but I want to hear from the community. I think it was a very strong message you gave about chemotherapy, and I think some people maybe in this group might have found that upsetting because they've gone down that route. They followed the STUP protocol and took what the NHS has offered. But it is a very, very complex landscape in the UK. And I know that we have medical and clinical oncologists that feel bound by the NHS. They want to talk, and I know this because I'm on the British Neuro-Oncology Society's committee, and I listen to the clinicians talking, and there's a huge divide at the moment where some clinicians don't feel it's their right to gatekeep this information. They've got patients before them who are asking what else is out there because they know chemotherapy doesn't work in the long term. So we've got, 50% who want to talk about these types of treatments, and we've got others say, no, we can't talk about them because they're not offered by the NHS. And it's a real pain point for clinicians at the moment. We've got some saying it's not our right to gatekeep, and others saying, but we can't share them because they're not offered internally in the NHS. And we also know, we saw the example of Justin Stebbing, who was a fabulous breast oncologist who was struck off because he was recommending treatments outside the protocol. And the General Medical Council does have a watchful eye, and I know that some of our clinicians feel that they're not able to talk openly about these kind of things. We wouldn't endorse any treatment. What we do is enable people to use us as a sounding board. So, and we just gather the information that you give us and we put it on the website for people to find out and then come back to us and talk through. But yeah, so over to the community. I'll shut up. What do you want to talk about? You've got, fabulous resource here. Ask away.
So I have a lot of questions, if you don't mind. I want to ask the first question to Pete and Hannah, whether I'm allowed to show the movie, which you sent me in October 10th. Oh, no, beginning of October.
Yeah.
Is that okay?
It's a public video, it's out there, and so absolutely.
Happy beautiful day, everybody. Pete Cohen in
Hold
the
on.
house, and here is Hannah. So, what can you say? She continues to make such an incredible amount of progress, and I would never have thought this was going to be possible, to see her just recovering, but also now just getting stronger. It's hard to put that into words, but literally, as many of you know, a few months ago I wasn't looking too good, but now Hannah is just getting stronger than ever, and she's turning into are you competing in the next Olympics?
Yeah, I was static rower. I can't row on the water.
Not yet. You're not a big fan of water.
No.
Would you want to just say hi to everyone?
Yeah, hi, I'm trying to.
She's concentrating.
35 strokes a minute. I'm not there yet.
And as she continues to get better, thank you everyone for the support. We want to keep you in the loop with what's going on. We go back to Germany in a couple of weeks for another scan, but this is a miracle.
So allow me to add a few comments. It might be opening the discussion. I trained in classical medicine, academic medicine, and that's what I want to continue to do, and that's what I'm doing, to understand the mechanism and to research it, to develop it, and to collaborate. The fact that colleagues are not talking about that, I'm guilty, because I didn't publish enough. We have a few case reports. I cannot do a case study with 100 patients. It's beyond our capacity. That's the nature of medical innovation. We start with one, and if we can have two, there will be failures. The alternative is known to everybody. So I have not a hard time, very clear explanation and a disclosure with a consent form that it is experimental, knowing that the alternative is what it is. If we will have 10, 20 patients which we can treat, it will make me the happiest guy 10 times or 20 times, because it's amazing to see Hannah and many others. We have quite a group of patients where we make a breakthrough. We can't publish it for regulatory reasons. We don't have the funding for financial reasons, but we will not give up. It has to be, as every disease in medicine, get the problem when it is a small one at the beginning. So what we need to do is to convince the doctors, if you have a brain tumor and you resect it, just leave an ommaya there. It's nothing. For the surgeon, it's nothing. He was inside and cut it out in the most sensitive pieces of the brain. When you clean it, to leave a little needle there, a little line, a tip, and to implant that, it's nothing. It costs nothing, no time and minimal effort. But afterwards, we even don't get the approval ethically to do a procedure which is potentially dangerous because of anesthesia in 1 of 10,000 cases. We don't get the approval ethically. I understand. We don't get the money. Who pays? So that needs a new way, a shift in the paradigm of thinking. With an end-stage disease, you get ready. What happens in 3 months and 6 months on day 1? So that is one preparation, to start right away and not to wait, to get the best imaging, which is not done. And we had patients where we had argument with the doctors. They did not agree, and we did afterwards, finally, on the expenses of the patient. We did the imaging, and it was a totally different disease. So instead of arguing, I'm not fighting, I'm not the smartest guy. They know much better what they do. But I know from the radiologist what we need to do. So we are at the very beginning of a pioneer work, and we need full collaboration, of course, all the support for the viruses, which we need to improve, and we need to make the viruses available that we can send them out to everybody in the world, because it's very simple to do it, but we need to develop the protocol, the radiology, and so on. It's a very early stage, and not everybody is built for that. On a personal level, I think that Hannah and Pete have a very good attitude, a good understanding, and they know exactly what they are dealing with, and with their personality, that was actually the key. And that needs a lot of resources. It's really might be one of the biggest challenges in life. So it's not easy. That's what I wanted to comment about with a little bit of proportion.
Thank you. We get people coming to us, they're absolutely terrified. They've just had the worst news imaginable, and they get overwhelmed when they listen to what the NHS doctors say, and they think, well, there must be more. And they just get overwhelmed with what's out there. What advice would you give to people in that position so they don't go down the road of choosing something that is snake oil? Because we've got so much, we've got immunotherapy, we've got repurposed drugs, we've got antivirals, we've got technology, we've got angiogenetic drugs. Where do you begin?
I don't have full answers on a general term, and I'm aware of the challenges. I see very often that people send around the specimen to all over the places in the world, and they pay thousands of dollars. And at the end, it says in little lines of 20, 15 pages of a lot of results and colors and references. It says at the end, ask your doctor, what is the next step? And I don't know. Sometimes there is an evidence. It's a total waste of time. Very often it is a total waste of time. But you know what? I really want to see these results, because I want to find out for our project when we have to try for everybody. And I don't see in these 15 pages, I don't see often, I have no clue what the conclusion is. I pick up the phone and ask the laboratory, so what's the conclusion? Oh, you have to discuss that with the experts. I ask experts, I don't know what's the next step. So that's fine. I'm happy they made an interesting analysis, but what do we do practically? I don't know. It's important to do, because in my research, I want to retrospectively analyze who did well. Can we use that as a predictive information? Who will do very well and who will be resistant? Still, I would offer it to everybody. So there is a lot of confusion. The honesty of the doctors, and it's not the job of the patient to treat the problem of the doctors, but I ask you to understand, very often the doctors, they can't just say, we have nothing to offer, go home. Oh, there is a new study coming out from England, and one from Boston, and one from Paris, and they offer you the best new research, which is not proven to be efficient. Very often the doctors get quite a lot of money for recruiting patients. So the confusion is huge. And I cannot deal with that, because that's the system, and that's a good way to make progress. Whether the patient will benefit or not, we have to be very careful. What I can say for the project we are doing here, we work on brain tumors and many other tumor types. We are very careful. we can't promise other than we will do the best we can. More I cannot promise, and even that's it's a lot of work, and I'm happy to do so. We cannot promise more, but we have to be very careful. I take only patients where the hope is the alternative is not good, because that's where I want to start, and whatever we can prove, minimal side effects, we can be successful. And I think it needs actually a support group of patients who know the way, who went through the way, and they probably know more than all the doctors.
Yeah.
They know more. My job is to publish and to approach the scientific community and to get funding. We talk about millions, huge figures of millions, not one and not two. It's a huge process, program with the regulation and lawyers and laboratory and you name it. But I think we should all put our heads together and do it in the best interest of every patient and the population of the patients worldwide. That was not very clear, because I don't have clear answers.
It's fine.
But I have a clear answer that we have to do the best and put our heads together to find the solution.
Okay, so I'm aware we're still recording. Are people happy for me to record, or would you rather I just stopped at this point? Any objections if we keep recording?
No.
Okay, so Pete, in a minute, I want to come to you to ask about how did you come to make your decision. But comrades, I don't know your name.
My name is Diana. Hello.
Hi, nice to
I
meet
have a
you.
question whenever it's
Yeah, and also Sarah and Andy have got one. Shall I do Sarah and Andy's first? So my husband has a GBM4, had a second debulking in October, starts lomustine shortly despite methylation status. What sort of money would this cost and how do you access it? Sarah and Andy, do you mean for the treatment from the Gesundheit Institute? Our oncologist has actually said she'll refuse chemotherapy if we try to access treatment outside the NHS protocol.
So once a patient is interested, I'm not allowed, and I will not do it, to make advertisement for the project. I do that pro bono because I work on another project and then do that in my spare time, which is taking a lot. And I organize the radiologist and trying to coordinate this treatment, quite a task. For the surgery, it is even with the best insurance, I haven't seen one single patient who got it approved. And we had recently, not recently, for 2 years, a patient with a renal cancer, which is an end-stage condition, stage 4, and he is cured. And he costs in the United States and in Europe between $250,000 and up to more than $1 million. And our treatment was less than 100,000. And I had my stupid mind to argue with a logic argument. Oh, it costs the system 250, which includes chemotherapy, surgery, and radiation, and many very expensive stuff. We do it for 100,000 and less. Why don't you pay just what it would have cost you in the medical system, and you pay to the patients? He can get treatment. Isn't that a logic point? It's logic, right? So I attached to the insurance company all the pictures, and I got an answer. No, it's not standard treatment, and there is no evidence that it is our treatment which cured the patient. So what I want to say is it's impossible to argue. If you don't have the money, it is important to get the money from fundraising, from a campaign. And it is hard because I understand the system doesn't support what is not known. The Ommaya, you can be in touch with me if you're interested in. What I would actually like to ask you is to send me an email, and we have a system, which is, I will show it to you how it works. That's my email address. Just a moment, please. You have seen my... That's my email. No. Here's my email address. I will show it to you in a moment. Hold on.
We can share it in the chat.
Yes, I will show it to you in a moment, but I will share you in the chat what I do here. Just a moment. I have to work. I will show it to you in a moment. We have a system where you need to register, and from the registration there. I got the messages, and we are overbooked with patients and have many issues to struggle. We try to do our best. Hold on.
Sarah, I can also put you in touch with Pete so you can talk to him.
Okay, here we are. Okay.
I can't see it in the chat.
Now you can see it.
Okay.
Okay, now you can see it. That's the website. Okay. You go to the website, and on the website we have here, contact us. We have the publications there, what research and what treatments we offer. You go to contacts in the website, and in the website there is a questionnaire where you fill in your name and email address and the title and the basic background, what language, these are the languages where I can help. And you submit the basic data. And with the data I will get afterwards, there's a second page, and at the end you say submit. Once you say submit, I get the note, and we try our best to offer the treatment, including the plans, whether we can help. If we can't help, we say that we are unfortunately not capable to help.
Okay, thank you.
So
Right.
we start the dialogue, and I think what I actually think is the right way to do for experimental medicine. It is very, very individualized. We have to understand the people, and the people have to understand that it is experimental and how they have to collaborate. And the patient support group will probably be better than every smart, intelligent explanation from my mouth. The patient, another patient can tell you much more than I can.
Thank you. I'm a bit shocked by the response of the oncologist. You know, I could understand them refusing chemotherapy if you were actually on another treatment, but for them or him or whoever to refuse it if you're just trying to access it just seems very, very hard, particularly when you feel options are closing down for you as well. Right.
Can I just say very quickly, you know, because just what you said, Hannah's been under the guidance of Dr. Gary Houghton in Queen Square for 13 years as her neuro-oncologist in terms of the prescription of her anti-seizure medication, but she's also been under the guidance of Dr. Paul Mulholland, and Dr. Paul knows exactly what Hannah is doing, and has kind of got behind. He has to be very careful what he says.
Yeah, absolutely. Yeah.
He knows exactly what Hannah is doing, and he's actually been out there, but not for the treatment of what Hannah's looking at. That treatment, he's been looking at some of the other work that they're doing over there in Düsseldorf. So we didn't really see any other option. You know, we really didn't see. Hannah started the chemotherapy and her platelet count dropped massively, so she came off the chemotherapy, and yeah, we haven't looked back. We're just looking forwards, you know.
But why this particular treatment and not, you know, maybe not the peptide vaccine from CGAT or IOZK?
Well, she couldn't get they wouldn't give her because we would have needed a sample, a tissue sample, and the original tissue sample was taken 13 years ago, and it wasn't stored in the right way. They wouldn't operate on Hannah. They wouldn't do another biopsy, so that a treatment wasn't available to her.
So a lot of options closed down for you at that point.
Yeah. So and Dr. Ziggy, who is in who I've known for about 7 or 8 years, who is in the UK, I reached out to him, and he presented a couple of options, and this was one of the options. And you know, obviously it was the right decision for us. I've put my email address here for anybody that perhaps also just wants to contact me, and I'll be more than happy to speak to anybody.
Yeah, thank you. Right, Conrad, at last. Sorry, what's your question?
Thank you for the presentation. It was very interesting and informative. My knowledge about GBM is very limited because my husband only got diagnosed this year. But from the little I understand, the tumor can have different properties. You obviously haven't got any official numbers. I was wondering whether you could tell us how many patients have you treated, and has this treatment perhaps been unsuccessful for some of the patients?
So we don't have statistics. We have several dozens, and some did very well. A lot. Somebody else in Germany treated till last year, and unfortunately he passed away. I worked with him for 6 years, and now that was the 7th year. And in the 7th year, I was blessed to take over. I worked very, very intensely with him with the radiology. We were not capable to do statistics, but we had some. You saw it in the paper, which is online in the link where you will see. There is a website, and our research is published. So he had very, very non-systematic treatment. It's not my type of work. I'm trying to be very organized and very well documented, and feedback from the patients. And we had patients who failed, who got exactly the same as others. I don't know the biology, but I can tell you, once it was progressed, we had very poor results, which is logic. You don't need any intelligent comment on that. We had actually a patient who was end stage in a coma, and he got 2 treatments and he woke up. He had very, very extensive disease, and he was for 11 weeks in a coma, couldn't drink and eat. And the father decided much, much too late to come finally to treatment. And he woke up from his coma, and he could eat and drink and even write WhatsApps. But the disease was that much progressed that the treatment and the disease, you saw it's an immune response. And the immune response in the finger takes a week or whatever it takes. In the tumor, the immune response, it's a harder fight. And GBM might even be more tough than only anaplastic astrocytoma, which is WH stage 3. It's still bad enough to be fatal. So if we don't start early, it doesn't work. We tried at the late stage. We don't take patient at the late stage anymore. We ask for a Karnofsky performance score. It means what is the capability of the patient to take care of himself cognitively. And we want to cure. And we want to collect patients where we cured, because to try end stage, we will see a radiological result, but what's the point? We are not working on the program, we are trying to treat. So I encourage strongly, if somebody says he read online what GBM is and he gives up, I'm not going to fish any patient. Whatever the decision is, it's his decision. I will fully respect and pray for him. If somebody wants a treatment, you better do it right away, because it's never too early. If everything is stable and the doctors, and there is a lot of psychology, I think I could write a book on the responses of the doctors. Oh, you never know. There are miracles, and a new study came up from Pittsburgh and another one from I don't know where. And they talk and talk because they can't admit, I have nothing to offer you. So take them with a little bit of peace, a grain of salt. If they don't know and they don't tell you it's end stage, understand it's hard for them. Let the patient think whatever he thinks, and I can't do anything. But if GBM, you can check it in Wikipedia. It will take you 1.5 minutes to know what the prognosis is. If you decide to go for it today, if you decide not to go for it, make a decision. I'm not going. But the patient I told you before, who came when he was 11 weeks in a coma, a year and 3.5 months before, I went to visit him somewhere else. I was in Europe, I went to visit. To wait, you don't wait with glioblastoma. A sleeping dog will not stay asleep. GBM is not a sleeping dog. If you decide to do it right away, the earlier the better.
Thank you.
Any other questions, comments?
I'd just like to say one thing. Thank you very much, Dr. Gesundheit for your very interesting talk. I'm the father of my daughter, is the one with the GBM. She seems to be no change in terms of her MRI. She's had the stopped protocol, and we are looking for other treatments. You said the sooner the better. If there's been no change for a few MRIs, is it best to wait until there is a recurrence so that you can treat? Because you talk about the Inrra system with in which you do a little biopsy and put the object in the brain, but she's gone past the resection stage many months ago. Does that mean you have to do another? You have to do it that way, or there's no other way because of the blood-brain barrier, the viruses that can't get through? I was just wondering about that, and also about your previous writings about oncotherapy. You mentioned about combination therapies. Is that something which you still advocate? Because in some ways, the oncotherapy seems to, as you say, re-energize or prime the immune system to work better. So when you were showing those PET scans, you said they're very small amounts. Surely, if the immune system has been primed, would it be in a better position to eliminate those residue kind of cancer cells? I'll stop there, but obviously I have to talk about it.
So the connection of the voice was not very, the microphone was not very good. I heard some pieces, and I'm not sure if I understood everything. I understand that your daughter has, it is a stable disease with GBM, and to wait or not to wait. I never call GBM a stable disease. It's not an appropriate statement. GBM is always progressive disease. Sometimes you see it, and sometimes you see it in 3 months or 6 months. So that is the attitude to write a stable disease. It's true, the radiologist likes to reassure you, oh, it's all fine. No, look at you saw the survival curve of GBM. It's not a line. It's always going down. So don't talk realistically about stable disease. Of course, I have another philosophy, because if I have something to offer where I think potentially we can cure, I tell you the earlier the better. But if I have nothing to cure, enjoy the day, enjoy the months, enjoy Christmas, enjoy whatever, the next birthday, enjoy what you have to enjoy in life. I never call it stable disease. Terminology and stable disease for GBM is a misnomer. So if it is stable, I call it, that's the opportunity. But if you don't see it in the proper imaging, I cannot tell you if I need glasses and I don't have my glasses on my nose, I cannot say you, oh, everything is great, it's stable. Might be we do the PET and we do the sophisticated radiology, and you will see it's not stable. And if you see in 3 months, it's not stable. So it makes me, I understand why they say it, because the doctor has nothing to offer. That's he has to say. I have a lot to say here. I have a lot to offer. And we need the team, and we need to understand, try to treat, for sure, a young patient, not a lot of underlying other problems, so we can offer something. I would recommend, when we start with the patients, we review the imaging with the radiologist, and it takes her 2 to 3 hours to review it, and I sit with her on each patient at least for an hour. And we look from all angles and all techniques. And then we discuss where can we implant it and where is the best place. What was given before, what helped, and what failed. And we know very well what helped and what failed. The initial surgery helped, and afterwards the radiation helped, and then it's very soon, it's going downhill. If there is this window of opportunity, we call it the honeymoon, that's the time to step in. I think I couldn't answer, I didn't understand all your questions, so please repeat loudly.
I was asking
to address.
Yeah, can you hear me now? Can you hear me now?
Yes.
Yeah. I was asking about combination therapies. You discussed in your introduction to that book, you as editor, about combination therapies like dendritic cell and oncolytic viral therapy. Is that something that could be
Yes. Yes.
considered? Yeah.
So what helps in GBM? Not a lot. Surgery helps if it is MGMT methylation positive. It helps a little bit. The survivor curl opens a little bit, but both are going down. So we take whatever helps. Unfortunately, not too much. Is the helmet of help? We didn't include it because I think the quality of life of the helmet is not that easy. We might consider it. But viruses, and we are, I think, the only group who try to take different viruses, because we are not running after the patent and after a business. Which viruses? We take 2 different viruses and think that the combination is stronger because from animal research for other diseases that's known. So at the end, we're not going to market virus 1 or virus 2 because we think it's the best for the patient. And that's the only interest that guides us. That is one combination. If at the beginning of the so-called Stupp protocol, by the way, he saw our data and he was overwhelmed. He says that's the future. I mentioned him in the acknowledgement in this in the case report. If radiology is given at the very beginning, it's given for a good reason, because radiology is successful to kill quite a lot of the remaining tumor cells. Why do they give radiology if the disease was resected with clear margins? Because everybody knows the clear margins is a misnomer. There is no stable disease and there is no clear margin. It's a total brain disease from day one and not curable. So don't call it curable and don't call it a stable disease. The radiation has a chance. And it is known that the viruses, they work better to irradiated tissue. So that is, you find it in Google. You don't need to go to PubMed. In a lot of animal studies done, because they are approved, they took viruses and gave radiation. And the radiation prepares the tissue to be more vulnerable to viruses. So what I want to do is to ask the Stupp protocol. You have at the beginning surgery, radiation, and Temodel, if positive. I want to have the surgery done at the beginning. It's the best debulking. The surgeon takes it out with the knife. It's out. We need a diagnosis. We need tissue. In the ideal case, I would like to take the tissue and put it like pus from the emergency room. When a patient comes in with a big pus, a big wound, take a little of the pus and put it in the lab and check which antibiotics is sensitive and which not. We don't have this setup. That's the dream for the next stage. Take every patient's pus, no, brain tumor, and check which of the viruses. So we know which viruses we use and they're very good. If they give at the beginning radiation, I want the radiation to be part of the OV treatment because they work better in combination. Let's benefit from a synergistic effect. If I can kill a wild animal with one shot at the beginning, why should I wait till he wakes up and he starts to bark? Do it at the beginning right away, because radiation is in most cases well tolerated. The tumor is out and that's the window. That's the honeymoon. Surgery, implant the ommaya, start radiation together with very, very, very mild OV. That would be the combination. So most patients today approach us when they are end stage and we can't offer anything. Others come at a reasonably early stage, but radiation is done. So that is what I want to do. But to give everything that is offered online, I review the literature. I'm in the I get these alerts, Google alerts, what's offered. Yes, it's good marketing, but not in the best interest of your patient.
Yeah, thank you.
Beni and Peter, thanks very much for that presentation. I guess hearing something like this is very encouraging, and I can feel my heart beating faster as I watch this. So if we complete your online document and we have a discussion, what is there the reasonable waiting time for an operation? Because you indicated that you have a lot of patients to treat.
So we face a lot of issues, and we are a very small team. I'm the doctor from Israel, and there are people in Germany who actually give the treatment. It's all based on a team there. So I try to do my best, and I work as much as I can, full capacity. And we need to get the viruses ready. There are a lot of challenges. We try to normally, when we get all the data, and I have people who help me with assist me with the online registration and the radiology. Normally, when it's really going fast, within 2 to 3 weeks. But very often there are obstacles on the way with the viruses and so on. There was so I cannot promise, but if you are in touch, the way to communicate is to register, because that's the way legally. We pay a lot of attention to do it in the legal way. It's experimental and new. We don't want to take a risk on semi-legal procedure that you just called and the patient told me, and there's a lack of data protection of the patients. We have enough problems. So please register by clicking and submitting the name. You agree to the way we manage the data. So everything is protected with double passwords. And I will try to answer within 48 hours, which I cannot do every time, always. And there was another question from somebody else, whether we can do non-operable tumors. So none of the GBM is a good condition, but we had a patient with a huge non-operable tumor who got very good radiation in Israel. And there was a oncolytic. We like to see the oncolytic cavity in the tumor, which was not seen for this patient. We saw it in other GBMs. And this patient had a huge, bigger than an egg tumor and got a stereotactic radiation exactly to the tumor. And we went afterwards, if that's the tumor, let me share it here. That's the tumor, okay? This whole bowl. The radiation caused it to be like an eggshell, okay? And we went afterwards with the Ommaya directly in the middle of the empty tumor space. And so we use this non-operable tumor, which was irradiated very well, and we go with the tip of the Ommaya in the cavity, and that's the effect of the Trojan horse. We go with the viruses and attack it from inside. From here inside, the tumor will be attacked from the inner surface and will follow the tumor, which spreads all over. And we saw very interesting results. Do we have a lot of patients like that? No, we collect, we try for every patient. And all of a sudden I see one patient, oh, he reminds me the other patients we had a few months ago. And we compare the dynamics, and very often the biology behaves similar, not always. We had the most unexpected responses on these tumors. So we don't have enough data, but we work very hard to offer every patient individually the best we can, and to learn afterwards from the accumulated experience how to do it better. That was not a very satisfying answer. That's where we are. That's the way of pioneer work.
What's your vision, Dr. Beni?
Sorry?
What's your vision?
What's my vision?
Yeah, for people with glioblastoma or anaplastic astros.
So it's different. I mean, they share in common the poor prognosis. The vision is that once we publish our preliminary data, and that's what I can do on my little in my little framework, to publish, invite others, get a lot of funding for viruses, that you can do it in England. It's not fun, Pete and Hannah, to travel for every treatment, even for the imaging, to travel a few 100 kilometers. And just to get it there, do a very expensive test, not covered by the insurance, and travel back in another language. It's not fun. So my vision is, if we can get these viruses and the treatment published, and we can offer it to patients worldwide, and they can, oncologists, if once they understand, and they will set up the team, which is a neurosurgeon for Ommaya who will do it at the beginning. Easy. Every medical center who treats GBM and other brain tumors, they have neurosurgery, and to insert the Ommaya is nothing. It's the first procedure a resident learns in his training. It's the simplest. So that's possible. To inject viruses, you need to know how to inject. Everybody knows that. So that is the long-term vision, to bring it to a level that people worldwide could benefit. I have a great interest in children, to treat children, including DIPG, which is a totally horrible condition, diffuse intrinsic pontine glioma. And there are data in animal research that it could be helpful. So of course we need to do it.
Thank you. Are there any last words from anybody?
I'd just say that if you do go down this road, it isn't straightforward. You know, it isn't. There's no question about that. You know, our biggest expense has been actually going to Munich for these PET FET scans. They don't do it anywhere in the UK, but that's part of what the reporting that is needed for Beni and his team to really see what is going on. That has been a challenge, but I suppose that the alternative for us was, well, there wasn't. This was the alternative. But I've put my email address, and if anyone has any questions at all, you know, just feel free to reach out to me, and I will do whatever I can to help and support anybody that's choosing to go down this path. It is not straightforward.
No.
But it's definitely worth a shot, I would say, for
Yeah.
sure.
Yeah. So thank you. It's been a real privilege. And, you know, I do feel an affinity with Israel, because it was Rabbi Fira that set us on the right course with my daughter, who had a grade 2 glioma. And without that expertise coming out of your country, she wouldn't be here now. So, you know.
Here, he's my distant cousin.
Oh, is he? That's amazing. Well, he saved my daughter's life.
Very good. That's the way it starts. I want to
Yeah.
re-emphasize that this treatment is experimental. I'm not advertising, but if people are interested, I will try to do my best. And I ask you as a little community, if you want to do it. Pete and Hannah were extremely smart and developed a proper personal attitude to do that. I'm very happy, Pete, if you could help to guide others. And if you find a group who will follow exactly what we need, and if we have a patient who needs to wait 3-4 months for an approval for a PET FET MRI, and I know for sure he doesn't get it because it's not approved in England, one has to understand upfront. You go to Germany for the imaging, and a few days later you start treatment. Anything else is a waste of time and inviting troubles.
I think one other thing
you say that.
One other thing I must say is that Dr. Andreas, who runs the clinic in Germany, who is the surgeon, he is an amazing man and a fantastic surgeon. And also Dr. Shamibas, who works there as well, because Hannah also had some infusions when she was there. She also had the hypothermia
treatment, which will be available in London soon. Yeah.
But thank you so much.
Des, I want to add that to Mr. Anthony Smith. You asked combinations treatment.
That's right, yes.
How did I forget? Hyperthermia is offered very often. It gives you the change in temperature. It gives a little bit of a help of the immune response. It's not curative.
Yeah.
Vitamin C and curcumin and you name it are not curative, but they modulate it a little bit. If we give it together, so this synergistic effect makes, for instance, a side effect of the OVs. When there is an immune response, it calms it down and we can move on.
Yeah.
And the treatment is much better tolerated because we give the proper environment. The proper environment in itself is not curative.
Yeah.
If it is an additive, supportive effect to treat, the oncolytic viruses can kick in well.
I mean, you mentioned in your 2017 editorial about dendritic cell as a combination with oncolytic virus therapy.
So
Is
the
that something-
dendritic cells, these are fascinating biological cells. I actually had them on my slide with all the details on it. They are there. I have not seen that dendritic cells in itself are curative for GBM. But if I have not seen that, I can just say I haven't seen that. I might be very blind.
Yeah.
But if it helps, everybody should come to the table and let's combine it. I have seen for Hannah, which I presented, and you can talk to Pete, there was nothing else. Yes, there were some Chinese herbs, which might be good, but might be not good because it was not the turning point. I'm not rejecting any option if it helps. But if you say at the end, I had 2 bananas during this week, so we need to eat now all day long banana, it's not convincing me. But it's very good to eat whatever you like. So we have to be critical. What is really on the table for the treatment and was not. I try to show you that we are very critical with our success. The MRI is not no evidence of disease condition. It's not stable disease. Bullshit.
Yeah.
Nobody should convince me. So we should discuss with a team of doctors and experts, what do you want to bring? I'm open to put on the table. Table is big. But if at the end the patient has 17 treatments every day, the quality of life can't be good anymore. So I prefer to pick what's the best and tell the others, you like banana, enjoy, take strawberries, they are delicious, but it's not part of the treatment.
Okay,
Thank you.
Melinda, and then
Yeah,
I think we must go because it's already 1:30. Yeah.
it's going to be real quick. I live in the States. My daughter has astrocytoma, grade 4, IDH mutant. My question to you is, do you know what hospitals may have the type of scan that you're referring to, the PET scan?
In the States,
Yes.
I'm not familiar. I know they do a lot of research. It's a lot of basic research. Since the treatment can be given in Germany only for regulatory reasons, of course, it adds some 25,000 euro, which is a lot of money. And it's a trip of 500 meters, 5 hours, 500 kilometers from Munich to the other place. So it's expensive. It's a big effort to travel. And if somebody is determined to do that, I can only offer what I know.
Right.
You can
Yeah, I
find
mean,
places-
certainly, I think at this point it would, you know, she's had her surgery, radiation, chemo, she's doing great. I would like to say that she's in the honeymoon stage. She went skiing for 5 days in Lake Tahoe, so she's doing great. But I guess my question is that I'm first of all, I apologize, I got in late, but I missed basically the beginning of, well, you were explaining the scan and how it seems to show more detail. She's been having her scans every 2 months. They've been clean. She's, quote, cancer-free, and of course I don't.
So allow me to suggest, because these are getting specific questions, I'm happy to take them. But I think the best would be that you register.
Okay.
And we will know all the data, and I will ask all the summary of the disease, of the course of the disease, and I can talk in a more specific way. You are not interested in theoretical questions, how basically what we can offer in a theoretical level. You want to know what can be offered for your patient.
Okay,
so that's
well,
more appropriate to do it on a very specific level.
Right. Okay, so I'll go ahead and do that. We've done that at several places, so thank you.
Thanks, Melinda. Okay, I'm going to let Beni have his afternoon back now. What time is it? Are you ahead or behind in time? I can't remember. 2 hours, I think, anyway. So thank you hugely for your time.
Thank you very much.
Thanks, Pete.
Wishing you all the best and a
Okay.
lot of energy to fight cancer. Don't give up.
No, thank you. Okay.
Thank you.
Bye, everybody.
Bye.
Bye.
Thank you very much.
Send me the link, Helen. Yes.
Will do. Absolutely. Will do.